Welcome to The Pulse, the official podcast of the Georgia State Medical Association.
Well, hello and welcome back to The Pulse. We are so delighted to have you join us once again for an amazing conversation. And as I always say, being a women's health specialist, I love being able to lean in and learn from my colleagues just as much as you. So I feel so empowered and so much smarter after these conversations. And tonight, we are going to have a conversation around weight loss, weight management, all the things. There's so much buzz out there in our communities, on social media, especially. And who better to join us but Dr. Shani Belgrave? I'm going to bring her to the floor. But let me tell you a little bit about Dr. Shani. She is a leading bariatric surgeon in Atlanta, where I held. She's board certified and fellowship trained, dedicated to helping patients transform their health and reclaim their confidence through weight loss surgery. Y'all, she was recognized by the Atlanta magazine, which is a huge deal, as a 2026 top doctor for the second consecutive year. She combines surgical expertise with compassion, empathy, and a deeply personalized approach to every patient journey. Dr. Shani earned her medical degree from Brown University, completed her general surgery residency at the University of Maryland, and pursued advanced fellowship training in minimally invasive and bariatric surgery at the University of Washington. I am so proud to tell you that she is the founder and CEO of her own Oneka Bariatrics in Atlanta. And Dr. Shani created a boutique practice that goes beyond bariatric surgery by embracing wellness, empowerment, and lasting change. She specializes in gastric sleeve, gastric bypass, and other minimally invasive procedures. But her work extends far beyond the operating room. She has emphasized comprehensive care that includes nutrition, preventive health, mindset, support, and long term follow up, ensuring patients feel supported at every stage of their transformation. She is also not new to this. She has been the host of her own podcast called The Coalition Talk Show, dedicated to health, wellness, and inspiration through candid conversations, expert insights, and real life stories. She helps listeners navigate their own journeys toward healthier, more empowered lives. And the thing that I love most about Dr. Shani is that she saw that it was befitting not only to focus her practice in the world of bariatric surgery, but she is also very well versed and capable of having the conversation around medical weight loss. I know a lot of you, okay, I'm just going to go ahead and be honest, a lot of us have been getting help, but a lot of people also have been very, a little squeamish and a little bit hesitant about beginning the GLP-1s and around that conversation when it comes to weight loss in general. So I am so honored to welcome alongside me to have this conversation Dr. Shani. Welcome.
Thank you so much, Dr. Adams Birt. That was such an amazing introduction. I'm so glad to be here.
Awesome, awesome, awesome. So let me tell you, the very first thing that I want to address is this. We know that there's bariatric or surgical intervention, and then there's medical intervention. But before we even tackle the difference, who's the right candidate for each, can I just tell you, because I am a gynecologist, a women's health specialist, and a lot of my patients, of course, are dealing with perimenopause and just entering menopause. For some reason, Dr. Shani, I find that a lot of women that they're blaming and shaming themselves around the the difficulty that they find in, achieving their weight loss goals. Can you just address why getting a little help or a lot of help in some situations should not be taken as a failure, should not be seen as a failure on our patient's part?
Wow, thank you so much, because that really is such a key part of what goes on, is that when we look at health, there are certain conditions that have become stigmatized, unfortunately, and
Yeah.
obesity or being overweight is one of those conditions. And I say it all the time, if someone has high blood pressure, they're not really shamed for getting on a blood pressure medication, even if they've tried low sodium, they've tried working out, they've tried eliminating alcohol. If they end up on prescriptions for high blood pressure, no one really shames them. But we are still trying to get to the point where obesity is recognized by the masses as a chronic medical condition, because it is.
Hmm. Exactly. And so I spend my days, Dr. Shawnee, daily trying to get women to see that the difficulty around the weight gain
Mhm.
that happens to a lot of women, especially in midlife. And I know this is not just a conversation for women, but y'all, I'm a women's health specialist, so
Right.
that's where I think. But that midlife weight gain, I have these conversations, I promise you, on a daily basis. So first thing I want to know is, what do you think of? Like, how do you decide? Are you having the conversation straight away? Who you're having that conversation with straight away with to discuss surgical intervention versus medical?
Absolutely. So, as you mentioned, my center is comprehensive weight management, offering both medical and surgical weight loss. And so, many times when people come in, they are there for consultation to lose weight.
Hmm.
And so, depending on their overall health and their body mass index, kind of guides that decision making. So, body mass index is a number derived from height and weight. It's not a perfect tool, but in general, if you have a BMI of 30 or greater, that corresponds to obesity, which is just the medical term for excess body fat. So, people that I think should really at least consider weight loss surgery are people with a body mass index of 40 or greater, or people with a body mass index of 35 or greater, particularly if they have obesity related health conditions. Some of the common ones are high blood pressure, diabetes, and sleep apnea.
Got it. So 40 or greater, or those with a BMI of 35 or greater who have some of these chronic conditions. Is it because the medical options aren't going to work as well, or we're trying to get to success a lot quicker?
So there's a few different variables. Like there's certain people who have metabolic syndrome, people that have diabetes, high blood pressure, high cholesterol. They are maybe 45 to 50 years old. They need to lose 100 plus pounds. And so a lot of those patients, they are wary of having been on a lot of medications, and they're trying to get off medication.
Hmm.
And so those people I think are a great fit for metabolic and bariatric surgery, because with the surgery, there's often time that you can really reverse a lot of those things and get people off of their medications.
Hmm.
So I think that's some of the decision making. And with the medications, the weight loss is not quite to the level as surgery. So it's less weight loss. But the other thing that I think is an important part of the conversation is looking at obesity as a chronic disease and what's the right tool at the right time.
Hmm.
Because with the medications, people are regaining if they come off the medication. And so a lot of people are what appeals to them about surgery is I'm trying to get off of medication. So I think that that's part of
Yeah.
how patients are deciding which way they want to go.
Good, good, good. I think that's great. Um, I think though other misconception is that it's an easier option,
Mhm.
and I think there's a commitment, right, that you have to really accept and engage with for both options, right? Because you
Mhm.
just mentioned people regain their weight. Um, I'm thinking about a whole lot of my patients, and I'm going, I've had some patients who have admittedly regained, or maybe they plateaued, their weight loss plateaued from maybe surgery from umpteen years ago,
Mhm.
and now they are considering a weight loss medication. Namely, we're speaking of the GLP-1 medications. There are some older versions of medications, been out since the 70s, like phenamine, right? But I'm just thinking about those patients. Would you then look at resurgery, or does the criteria around BMI and all the other list of chronic conditions matter? And those patients who may have been um, surgical candidates in the past, but perhaps they plateaued and they haven't continued successfully in their weight loss journey.
Yeah, that's a great question. I think that medical management is a great tool for people that have had weight loss surgery, that have reached a plateau, or have dealt with some weight regain, as well as getting plugged back in with their surgeons, just to make sure there's not an anatomic issue
Hmm.
that needs to be addressed. But if everything is looking as it should, then I think that in that instance, that's one of the great um, avenues, is to add on a GLP-1 medication to help.
Got you. One of the biggest fears is, of course, regaining, right? After folks have lost it. What helps people maintain long-term success? And maybe if we look at it from the medical versus the surgical avenues, what is the most helpful?
Yeah. So I'm going to answer both questions. In terms of the surgeries, the common ones being the sleeve, the gastric sleeve, or vertical sleeve gastrectomy, though they're the same surgery, and then the gastric bypass. Those are the two most commonly performed bariatric procedures. So in terms, those surgeries are very durable, and many patients greater than 10 years out have maintained the bulk of their weight loss. There are some patients who suffer with weight regain after surgery. And I think a large part of that is the consistency, because the surgery is a tool, but there's certain things you have to do to maintain that tool. So I always tell my patients, it can seem like something small. For example, drinking soda. Soda is super high in sugar. And even if you've had a sleeve or a bypass, if you're drinking a lot of soda, eventually
Hmm.
that weight is going to creep back on.
Hmm.
Or if you used to work out 3, 4, 5 times a week, but then as time has gone by, you've stopped working out. Those are the different things that can contribute to weight regain. In the case of medical weight loss, which is right now the popular drugs are the GLP-1s, the studies have shown that even patients who were maintaining the lifestyle changes still regained some of the weight. And the reason is because you're losing the benefit of the drug. So it's not just the lifestyle that's
Hmm.
helping you lose the weight, it's also the mechanism by which the drug is working in the body.
So, with that being said, because I I kind of get a little disappointed when a
Mhm.
patient comes to me who's already been on it. I'm not starting them on it, and they go, "Oh yeah, I'm coming off of it,"
Mhm.
or and I'm going, "Oh, you are? Did somebody tell you?" Right? And they just act very surprised. What I have learned, what I understand, is that it is should be looked at for life. You mentioned,
Right.
chronic conditions. People typically, and we know we have those patients too who go, but my blood sugar is great. Yeah, but is your blood sugar great because you're taking metformin or whatever? Or my blood pressure is normal. Is that because of the medication, or is that because, and maybe we can look at them differently, but I still think that stigma is there when it comes to the maintenance.
Mhm.
So could you just speak to that a little bit more?
Absolutely. I think that, as you said, there's a lot of stigma surrounding weight management. And not only externally from other people saying things to people, but I think some people feel a sense of shame internally, like, well, I'm just going to use this just for a little bit, just so I can kind of work out and do the things I know I can do, as though it's a personal failing if you maintain being on the medication. And so I think that's why it's so important for podcasts and public education for people to understand that it's the biology of the whole situation. It's not
Mhm.
simply willpower. Of course, you have to
Right.
do the things you're supposed to be doing, but it's more than that.
Right. I did watch a podcast a little while ago. It was earlier this year. Um, Very well known billionaire woman, I'll say, who I think co-wrote a book with endocrinologists. And the thing that I loved, when I'll just say her first name begins with an O, but one thing that I remember when what she shared was she too attempted to come off, and she did. She was on the GLP-1s. She had successful weight loss. She was very happy. And of course, a lot of folks go, "Oh, she's got money. She's got trainers. She can have a trainer in the morning, an afternoon, in the evening. She's got cooks, chefs. What is her problem?" And she admitted that the year break that she took, despite all of those things being true, having someone to, make prepare her meals and to work out with, she was shocked, as she says, that she gained 20 pounds back.
Mhm.
And I also heard the tennis star, who also speaks very, very highly and has become a spokesperson for a particular company, say the same thing, that they had to look inward and go, wait a minute, this is not to be ashamed about, but we need the understanding that maintenance may be important, right? And so that regain and that need to continue to see this for what it is. It
Yeah.
is a chronic medical condition, right? So,
Yes, I'm smiling. The reason I'm smiling is because I've had people I've spoken to about all this, and then they're like, "Oh, I saw these people on TV, the same people you're talking about, and I get it now." And I'm like, I told you
I
that."
just told you that. But hey, whatever works, we're all trying to get to the same goals. And I think
Yeah.
the biggest goals, personally, individually, people's goals may just be the scale,
Okay.
right? But can you also share with our audience members long term, right? We're not just talking about the BMI. We don't lean on that in totality, but we do utilize that. What are some of the other overall benefits when we, men and women, um, see the changes? What are long term benefits to health and longevity that they can look forward to?
Absolutely. This is one of my favorite topics. I call it non-scale victories because, as you said, the scale is a number, but there's so much more that people can appreciate beyond just that number. So it can be simple things like fitting your clothes more comfortably, being able to climb the stairs without feeling winded, being able to exercise for longer periods of time. I've had patients say, "Oh, I did a 5K." I mean, I've done things that I didn't even think I could do.
Hmm.
And so all those things point to improved, longevity, wellness, less fatigue. So there's so many benefits to maintaining your weight beyond just the actual pounds on the scale.
Absolutely. And I'm thinking about sleep apnea. I'm thinking about all of the conditions. What's it said? At least 200 obesity related conditions, right? Including oftentimes many cancers
Yes.
that are obesity related that we can benefit from. I had a patient the other day, Dr. Shani, who was in near tears. She's lost maybe 30 pounds, and her high weight with me maybe in the three teens somewhere. And she's seeing the scale come down. I think she was like in the 260, 270 range. She said, I've never looked at myself as being a supermodel. But the fact that, and she does have still school age children at home, she said, my knees don't hurt as much anymore. She said, and I never thought that that was possible. So I just shed a tear with her, and I gave her a hug, because I said, I shared with her this. Now, I graduated from medical school 25 years ago. And I told her, I said, the beauty of even introducing the GLP-1 medications to the conversation is that it is also not just changing your lives, it is also, of course, again, decreasing risks, but I think it's retraining the language. I said, because I'm going to admittedly tell you, we were trained. So now I feel bad, like I'm not going to say where I was training at med school and all, but it was not unheard of to say, medical student Shani, go check on that patient in room 2, the obese lady, or the the obese lady, or the man over there, the 350-pound man. We framed the whole conversation around their weight. And now I understand. I'm not in academic medicine, but in private practice. But now it is a reframing and a change of the language. We're going to take care of the woman in room 2, and her morbid obesity is a part of her medical conditions, but it's not describing her. And I think that is an important change. Don't you agree?
Oh, absolutely. I love where medicine is going because, you know, people are more than their diagnosis or more than their condition. And so looking at them from a perspective of whole person care is really the future.
Awesome. I think that is absolutely true. I want to address some things that we've done all the glam and the glistening and the lights and the great things about it. But let us do kind of share some of the concerns and the risks that can be associated with. First, I want to say, are there any bad things to losing weight? That's first. And then let's talk about the methodology to lose weight. What can you think of would be a risk to someone losing weight?
Well, there isn't really, like, I would say, a risk associated with weight loss. There are things to be mindful of. One is that people are not losing muscle. We really want to preserve muscle and lose body fat. So that's the weight that we're trying to lose, is excess fat. And then also with any kind of a weight loss journey, we want to make sure that patients are not getting any kind of vitamin or nutrient deficiencies. So focusing on the quality of foods that they're taking in and their vitamins, I think, are the big two.
Absolutely. So now let's shift and talk about risk to, um, surgical weight loss first.
Mhm.
What do you think of, or when you are prepping a patient, evaluating them prior to their actual surgical day? What is that conversation like?
So I always tell patients that weight loss surgery is safe, meaning that the rates of complications are low, but everything is risk benefit, and that all surgeries, no matter what surgery, always comes with some risk. So I always try to start there. There are certain risks associated with weight loss surgery. However, it is just as safe to have a weight loss operation as it is to have your gallbladder taken out. A lot of people don't know that.
Right.
So I think it's all relative because, as we spoke of earlier, obesity comes with the risk of certain cancers, a risk of
Mhm.
heart disease, so many things that are risky if you think about it. And so when you look at the overall safety and long-term outcomes from the surgery, in my opinion, the benefit outweigh the risk of surgery in the right selected patients. You have to make sure that patients are good candidates for surgery.
Absolutely. And before we move to risk with certain medical treatments, in your practice and how your protocols, how long do you walk with that patient, right? Is it something that you kind of hand off after a month, or do you continue to see your patients back? Or how tightly do you work with their primary care doctor or endocrinologist? Enlighten us about what to expect after the surgery.
I love this question because my patients will tell you, I'm tracking you down. You weren't here for a 6-month follow up, a 9-month follow up. Where are you at?
Good,
So
good.
I like to keep a close eye on my patients. So after surgery, I do a 2-week follow up, a 1 month. Then I see them 3 months, 6 months, 9 months, 12 months is a big visit, 1 year after surgery. And then at a minimum, I need to see them once a year. And I enjoy close partnership and collaboration with their primary care doctors. So I can keep tabs of, were you able to get off of your high blood pressure medication?
Yes.
Were you able to get off of your diabetes medications? And so that's one of my favorite parts, is the long-term transformation and getting to witness that over time.
I like that. I like that because sometimes, I think patient in surgical field, people feel like they cut out my gallbladder and it's like deuces. Uh, and so love to hear that there is long-term, um, not just connection, collaboration, but care and
Yeah.
concern
That's
and
the really
concern.
rewarding part for it. Yeah.
Absolutely. So now, just to be fair and to be clear, when it comes to GLP-1s, and I don't know, you're the expert in this area. I don't know, is it there's different types that carry different risks or safety concerns? Semaglutide versus tirzepatide, do they carry different, or are they all still kind of bulked under one heading and therefore carry similar or same risk concerns?
Yeah, that's a great question. So I'm just gonna break it down a little bit because in terms of the names of the drugs, this is a question I get almost every day. So the tirzepatide, which is the generic, the brand names for that are Mounjaro and Zepbound. And so these are all the identical drug, but Mounjaro was approved for people with diabetes, whereas Zepbound was the one for weight loss. And then semaglutide, the brand names for that are Wegovy, that was the one for weight loss, and then Ozempic, the one for diabetes. And so tirzepatide and semaglutide they're the same class of drugs. They're both GLP-1 agonists, but the semaglutide works on one receptor, whereas the tirzepatide works on two. So the tirzepatide does have higher weight loss than the semaglutide, but both drugs do work. Both drugs do work. And in terms of side effects and things like that, they're very similar. So some of the more common side effects are GI because they are stimulating GI hormones. And so that can be reflux, it can be nausea, vomiting, diarrhea, constipation. Some patients have reported skin site reactions or fatigue. If anyone has had a severe problem, like something almost looking like a bowel obstruction, then those patients have had to come off the medication, but that's uncommon. And then for both of those medications, patients that have had a family history of MEN syndrome or medullary thyroid cancer, that's a contraindication, meaning those patients should not be on it.
Okay.
But that's like the real thing that you have to, like, if you had that, you cannot take it. Most people can take the medications from a health perspective.
And that is good to know. I think that's excellent. I think that's excellent. So, as far as choosing which one, my understanding a couple of years ago is, as you mentioned, the Manjaro and the Zepbound, it was kind of only allowed if a patient had failed the other options. Is that still the case?
This leads me to another favorite question. A lot
Okay.
of this has to do with insurance, believe it or not.
Okay.
A lot of that has to do with insurance because that dictates some insurance carriers are like, oh, we're only covering this particular drug, period.
Gotcha.
So if you want us to pay for it, this is what it is. Yeah.
Got you. Now, I know all of our social media, what's that? Algorithms are set up differently, and maybe because I'm telling on myself that I do too much searching and looking at different weight loss conversations on social media, but I constantly am seeing um, pill forms, and I'm
Mm.
there ain't no pill form of tirzepatide. Now I know that there's a pill form that was FDA approved for Wegovy, but is it one and the same? What do you tell the public about using these compounded? I'm assuming they're compounded versions. What you know?
So I'm gonna handle the first part and then the second part because the first part was about the pill and then the second one was about compounded medications.
Gotcha.
So Wegovy did come out with a pill, and the side effects and all of that supposedly are not any different than the injections, and similarly, it is reported to be as effective as the injections. Interestingly, though, I have found a lot of people have wanted the injection because the pill is every single day and it has to be taken on an empty stomach, whereas the injection is just once a week and it has nothing to do with your
Right.
with your eating. So that was curious. I thought that more people would have been interested in the pill because it wasn't a shot, but so that's just more
Right.
anecdotal. But yes, so there is the Wegovy pill, and then Lilly has recently come out with a pill as well, but that just happened.
Okay.
So I haven't really incorporated that into practice yet, but it's coming soon because it's already hit the market. And then in terms of compounded medications, so the situation with compounded medications is that is not coming from the pharmaceutical manufacturers. That is coming from usually independently operated compounding pharmacies that take a generic form of the drug and typically will mix it with something else, a vitamin or something else. The issue that I have seen with compounding is that not all pharmacies are created equally. And so, depending on what's going on, patients really don't know for sure what they are getting. So, I think that was the concern with compounding.
Right. Okay. We are almost coming to a close, but I've got like two more questions. One, I want to know again, you are the expert in all things weight loss. So I am leaning on you. Age. And I'm going to give you a funny. I was going to say, I hope she never sees this, but I'm going to tease. My own mama went to her doctor and said, "Can I get on that shot?" "Ma'am, sit down. You 87. Let's praise God for how healthy you are and the weight you are. But is there a ceiling? And then how young for either? Like, what has your experience been with your bariatric surgical practice? But of course, this GLP-1 conversation, how young is allowed? What did the studies involve? That kind of thing. What age?
So I have got to say that my expertise there is somewhat limited because I only see people 18 and up, but I do know from
Okay.
looking at the packaging that there are indications for children, that it has been approved for children. I want to say maybe as young as 12, but I would definitely get with the pediatricians that are prescribing just to make sure. But it has been
Gotcha.
approved for kids. Yeah.
And how old?
I don't know that there is actually a cutoff. I gotta say, I haven't been blessed to have an octogenarian come in and ask, but it hasn't come up yet.
Oh my God. She tickled her doctor so much. He's like, "Ma'am, you're doing well." I was like, "Mommy, stop that. Stop that." So, okay. Before I let you go, can you give us maybe for that person who is feeling discouraged, especially because you already mentioned insurance, Some will cover, some do not want to cover. It's just automatically a denial. I know that the price points have come down over these last several years, which is great. I heard somebody say that it used to be like $1,200. I was like, what? Where was that at? And there are so many online programs. Um, where do you see that conversation around coverage? Um, because I feel like some people are just so, disheartened to learn that their insurance won't cover it. But do you feel like it's a safe option that some of these companies are, reaching patients directly and not necessarily having supervision and oversight?
Yes, that is a great question. And so, honestly, I think for patients, they need to consider if they are comfortable just doing something where they may have limited access to their physician and just doing something through a computer where it's more like a program or an app and then something shows up in the mail. If possible, I think what might be the better, especially because this is a chronic condition, I feel like what might be the better option is to become a part of a comprehensive center with someone you trust that you can have an ongoing relationship with, so they can do your body composition scan, track your muscle mass, track your percent body fat, talk to you about what you're eating and how you're doing with exercise and how you're doing with sleep, how you're doing with mindset, and also manage your prescriptions and any possible side effects. And so, as you said, even if your insurance doesn't cover the medication, there's a lot of more reason. It's still expensive, but there's a lot more. Even the companies, Lilly and Wegovy, have come down on their self-pay rate. So it still might be within reach.
Good, good, good. Okay. I did think of one more thing that I wanted to ask you again as a former obstetrician, now focusing only on gynecology. I still, of course, deal with the reproductive age women. What advice should I be, what direction should I be helping those patients who either have yet to have their families and grow their families or, want to continue? What is the advice, and is it different for those who have had successful bariatric surgery versus those who are utilizing medications?
So the key thing is, I would say, contraception, because it's important to prevent pregnancy while on the GLP-1s, while on a medication. And PSA, fertility goes up with weight loss. So there are people who've lost weight and gotten pregnant who are like, oh, I didn't even know I could get pregnant. Like,
Right.
suddenly they've lost weight and all of a sudden. So that would be my main thing, is just contraception if you're on a weight loss journey.
But is there a time frame when you have lost the weight that you should wait to
Oh,
actually
absolutely. Absolutely.
conceive?
So for patients that have had weight loss surgery, really recommend waiting at least 12 months, probably better to wait 18 months before conceiving. And a lot of that just has to do with the weight being stable, because with rapid weight loss, as things are shifting, that predisposes the infant to certain issues, nutritional problems,
Right.
defects, things like that. So you would definitely want to wait 12 to 18 months. Lean in towards the 18 months if you could.
Got you, got you. And as long as you are off the GLP-1s, probably not as long a time, just
Right. Because in that case, the concern is mostly the having the drug in your system at the time of conception. So
yep,
if
yep,
you're
yep,
on
yep.
if you're planning to get pregnant, then just to come off of your medication.
Awesome. Well, I'm going to stop here and ask you to take us out if there are any parting words you would like to share. But I want to thank all of you who have listened. And y'all, I'm not trying to be a bad host, but could you please stop for a moment and hit the subscribe button, and get your family and friends to also subscribe. This is just conversations from the members who are physicians of the Georgia State Medical Association, trying to give information for the masses. We are here in Georgia, but if you got an uncle and them in Kentucky you want to share with them, we do not mind. So that's my little commercial, and I'm going to ask you, Dr. Shani, to give your parting words, and we will see you next time.
Thank you so much, Dr. Adams Birt, for a wonderful conversation. Obesity is a chronic disease, so don't hesitate to reach out and get the help that you need, whether it's surgery or medication.
Awesome.
The content shared on this podcast is for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by our guest and host are their own and do not necessarily reflect the official positions of GSMA. At GSMA, we stand on over 130 years of medical excellence and advocacy, but we encourage you to always consult your physician or qualified health provider with any questions you may have regarding a medical condition. If you think you may have a medical emergency, call your doctor or 911 immediately. Until next time, stay informed, stay empowered, and stay well.